The feeling is mutual. Thank goodness my wife is here. She was watching. She would have been watching that. Our neighbor. Okay, yeah, one of the students from the gal is over in Cranberry West. Okay, she said she misses me. I'm telling my wife about this. Oh. I'm looking for a good babysitter. For the dog. No. For me. For you. For me. Did you hear that? Light housework. Okay. Let me get started. So, as the other people are coming in from the other class, we'll get ourselves organized, and I'll pick up where I left off here. Let me make sure we are recording. Everything is being. If it drops out, holler loudly. Send me a text. What? The chair. Well, I'll sit in my chair. Oh, that's so good. We just put it in. We got a new reclining chair. So, this is delightful. So I'll be very happy. Off we go. All right, this is kind of where we left off, everybody. There's very little to do left in the sympathetic nervous system, and really just reiterating some things about fight or flight. And you might remember this is kind of where we were. Okay. So again, we explore the cooperative effects, particularly with the sexual response. And so all of those things. So what's unique again about this is particularly the blood vessels, more than anything else, sweat glands, its effect on the skin, the erector pili muscles, kidneys. And again, it's not a direct effect on the kidney in so much as it's more about controlling blood supply to the kidney. But again, some of that sympathetic stimulation, and we will see in the next chapters that we explore when we start to look closely over the next 3 or 4 chapters in endocrine, which is next, and blood pressure, which comes in blood vessels after the heart, the physiology of that, and certainly in kidney, all about that renin-angiotensin aldosterone mechanism. That's a big player that's there. So, and again, this is just the point. It will cause the release of renin from the kidneys that will activate a system, and there's 4 major effects of this renin-angiotensin aldosterone mechanism that we will explore. The most important of which I feel is the aldosterone effects, which are the most long-lasting that are there. Metabolic effects, as you can see, metabolic rate, glucose available. This is fight or flight. You need energy. You utilize fats as fuels. It's just like going to the gym and you're doing a fat burn. Effectively, you're simulating this activity that's there. At the same time, you have to maintain your blood pressure. You have to change the absence of circulation going to your digestive and your genitourinary tract is to divert it to skeletal muscles, to divert it to the heart, to maintain blood pressure, etc. Okay, so the parasympathetic division, short-lived, very higher degree of control, and that's because of the rapid effects of acetylcholinesterase. Remember, the breakdown of the epinephrine and norepinephrine has reuptake probably plays the most pivotal role in that. And there certainly is going to be some enzymatic breakdown, and there's going to be some diffusion that plays a role into it. But the quick destruction by acetylcholinesterase is very significant. So the norepinephrine, as you can see, is inactivated more slowly. The hormonal effects, particularly from the adrenal medulla, that's the prolonged effect that we feel when we're excited. Or it takes a while for your breathing to restore, for your heart rate to go down. And it's a very good measure of fitness, by the way, is how rapidly to restore the resting heart rate. I don't know that we will do it this year. Maybe we will. I'll have to make some inquiries for one of the labs to do some of the lab, maybe do a lab at the fitness center. And it's interesting to see how very fit people, and as most of you are able to rapidly uh, after exercising, how rapidly your heart rate goes down. And I've got a couple of little devices that can do that fairly quickly without having to bring the whole megillah of things with the iWorks unit, which now I found the adapter for, so we're in good shape. And this is the summary page that's there. As you can see, okay, effects on, and look at all of those. If you just know this is fight or flight, dilate, okay, flattening the lens, secretions dry up in surgery, what we utilize. And I don't know what they're utilizing today. In the old days, we used something called atropine, which is an older medication. And atropine it would speed up the heart because it was parasympatholytic. But what it did mostly was act to block secretion. So if you had to intubate somebody, as you frequently do in surgery, you didn't have to deal with all the saliva and glandular materials that were coming out. So as you can see, this is it's different in what it does that are there. So you had something that the parasympatholytic was really the secretory activity was brought down with particularly that watery saliva is what I'm commenting on. The adrenal medulla you already know about, epinephrine and norepinephrine prolonging the effect. The idea of goosebumps when you're excited, but certainly I think more about the perspiration is greater. Heart, increasing rate and force of contraction. Heart, dilating those blood vessels. So those are more beta 2s than beta 1s. Urinary bladder, okay, relaxes the smooth muscle of the bladder wall, constricts the sphincter, inhibits voiding, decreases activity of the digestive system, constricts the sphincter, decreases defecation, dilates the bronchiole, again, those beta 2s, stimulating release of glucose. Gallbladder relaxes because gallbladder is active when you're doing digestion. The renin, and then which decreases urine output. So effectively, it's an antidiuretic effect, and we'll get into the things like that. We talked about the sexual aspects of it, and then the blood vessels constricts most vessels and increases blood pressure, constricts vessels of the viscera and the skin to divert blood to muscles. And I take issue with the brain, heart when necessary. Epinephrine weakly dilates vessels of skeletal muscles during exercise. So that's where it improves this. The brain thing, depending on, can you make an argument that there's more blood flow to the brain? Yes. Is it substantially more than the typical roughly 750 milliliters that are being utilized, on a regular basis, as part of the minute volume? I think not. Okay. So, and now increasing coagulation, that's of significance, particularly if someone has a clotting disorder, and perhaps more so if you're worried about someone developing a clot. That's a whole other issue. And then increasing metabolic rate and stimulating fat breakdown, which is where the exercise effects come in to play. We're going to spend an enormous amount of time on autonomic neuropathies. Okay, extraordinarily common in diabetes mellitus. It's such a long discussion that's there. It's been my experience, and understand everybody, for the better part of 25 years, 2/3 of my practice were diabetic patients, and mostly elderly. Of that population, between a third and one half of those individuals who had diabetes for any given period of time had, let's say 5 to 10 years or more, had autonomic neuropathy. We call it diabetic peripheral neuropathy. It affects the sensory ability more so than the motor, but it affects the motor in those nerves from the extremities. It starts usually early on. Sign is loss of vibration. It's one of the early indicator, and that's what we use the tuning fork that's there. But what happens is they completely lose sensation in their limbs, particularly in their feet and their hands. I mean, I think I've told you, I have pulled needles, I pulled carpet tacks out of people's feet that they didn't even know they had in them, nails that they didn't know they had in them. All the only reason they came into the office or came to see me was because there's blood coming out of their shoe. That's diabetic peripheral neuropathy. That's there. It's it plays such a major role. And then there's the impact that it has with regard to balance, the impact that it has with regard to walking and functioning is just enormous. And we still, to this day, do not know exactly what the pathway is. What we know, the approach to it is very early aggressive treatment to maintain sugar levels. And I'll talk more about it when we do the diabetes nugget. In men, particularly, this is an early onset sign, and I typically use the same anecdote about a patient who was referred to me by his diabetologist because he had not been treating his diabetes. One of these guys, truck driver, I don't want to with a broad brush, like to hunt, like to fish, like to drink his lunch, which a lot of people did up in northwestern PA. If you're familiar with what it was like, and I practiced in the Oil City, Franklin area for 20 years. The What this gentleman did was he didn't take his insulin. He was insulin dependent. He didn't watch his diet. He's this big guy, comes in, maybe a little taller than I am, probably weigh 250, 260. Why? His diabetologist came, sent him for me to take care of his feet because he had the neuropathy and she was concerned about any problems that could develop. And what brought him to his diabetologist? Sexual dysfunction. Here's a man in mid-30s experienced significant erectile dysfunction, and that got his attention. And so all of these, because of the autonomic nervous system takes care of regulating your blood flow, particularly to the brain, you get something called orthostatic hypertension. Okay, urinary incontinence. It, again, can't control the sphincters, and we just saw that that was a sluggish eyesight, impaired sweating. Okay, and again, the whole idea is very aggressive glucose level control. And we've seen this early on. Came from work that was done originally in the Joslin Institute, which is part of the Joslin group in Boston, where they had done it. It's out of Harvard Med and Mass General Hospital was where most of those things were done. So that's significant. I really can't emphasize it enough. This particular gentleman, I saw him for a few times over, let's say, a 6 month period. He came in, had lost a ton of weight, looked terrible, was very despondent because I found out he had, by not taking care of his diabetes, he needed a heart transplant. And at that point, I lost him to follow up, and I can only imagine that he probably didn't survive very long. True story. So here we are, control areas, brainstem, spinal cord, hypothalamus, cerebral cortex. The hypothalamus is the integrative part, and that's what we're going to delve into right after this. It's a wonderful segue into the endocrine system because that's our next system to cover. Yes, we can override the autonomic nervous system, but they do so subconsciously. When you're emotional, it's going to make a change. When again, despondent, psychological, depressed, that can make a change. Meditation, certainly you can lower your heart rate and your blood pressure. It's not easy to do. There's very few people who could do that consciously. Some uses of biofeedback have done that, which is interesting. They tried to do that before, where you could see a visible display of, let's say, blood pressure or pulse pressure, and actively try to focus your mind in such a way to lower that. And they utilize that for biofeedback to deal with certain problems that were there. Very interesting. I don't know if they do it that much anymore. The reticular formation, remember that? You recall when we talked about that in the neuroanatomy portion of the program, that had a lot to do with being awake and alert. So if you think of it being almost like hyperstimulated, okay, the medulla, you remember that's the brainstem deep within there, has the greatest role. Between the pons and the medulla are a group of controls, and we're going to look at those for heart rate and blood pressure and GI activities. The midbrain, because that's where the third cranial nerve comes from, the oculomotor nerve, and then obviously the spinal cord that's here. So you can see where these things are. The hypothalamic area has really significant impact. Okay. The hypothalamus is very, very small, but it's where the blood brain barrier is the weakest. So we are able to interpret chemical levels, acid base levels, a variety osmotic levels that are part of this control system that's so, whereas you can see if you anteriorly para, posteriorly sympathetic, and then you can, and also you can have other areas that function directly or indirectly. Directly would be means something occurred that caused it, almost like a reflexive, and indirectly would be generating additional hormonal control. So they can summarize them: heart, blood pressure, temperature, water balance, endocrine, emotional responses more through the limbic system, and certainly through the hypothalamus. Okay, plays a role in that as well. This is where the biofeedback nugget comes in. I wonder, I'm not surprised that that's where they would put it into. Awareness of physiological conditions and trying to influence them consciously. Uh, I think probably their application is greater for migraines and stress than anything else. I would agree with that. I saw it being used for an odd case of peripheral neuropathy in a veteran, in a soldier, when I was a student back in '76 down in Virginia. And it was at the Vets Hospital in Richmond. And he, interestingly enough, had leprosy. He had contracted this. They sent him from Vietnam to Africa, and he was stationed there for a year or more and had come in contact with leprosy. And the leprosy is what generated the neuropathy. And they were using biofeedback on him. I was also seeing him because he had real problems with kidney function as well. That's another one of the issues that they saw associated with the disease entity. And so there, you can take a look at the illustration. It's not bad. Okay, blood pressure. That's the big player, I think, from autonomic nervous system disorders, and it's so common. Almost anybody that you know. Okay, do half the people over the age of 50 take blood pressure medicines? Probably, I would think. Do they take at least one? Sometimes two. I take two. Okay. My dad had high blood pressure. My mom really didn't, but eventually they used effectively blood pressure medicines because they have dual duty with cardiac medicines. So I take something that impacts that renin-angiotensin system called losartan, this known as Cozar, and I take amlodipine, which is a calcium channel blocker that was previously known as Norvasc, and they are they're standard treatments with comparatively little side effects. What happens? Overactive sympathetic vasoconstrictors. Again, sympathetic's all about blood vessels. That makes the vessels too tight. Hypertension, excessive tension or tautness. The vessels are flexible tubes that expand, that rebound, that pulsate. And what happens is, like any tube, think when you're blowing up a balloon, standard balloon, kids having a birthday party. You're going to blow up balloons for a party you're having, and you don't have one of those helium cylinders or whatever you're going to use. You stretch the balloon. It reduces the degree of tension to a certain extent that's there. Your blood vessels are like that. They should be easily expanded and then easily returned to size. As we get older, that becomes less and less. The elasticity level limits itself. You saw that when we looked at the blood vessel anatomy in the anatomy part of the program. So what happens now? Your heart has to work harder to expand the vessels. Okay, there's an increased degree of wear and tear. Wear and tear breaks down cells. They become inflamed. When they become inflamed, that's the potential for them to cause longer term damage that will lead to atherosclerotic lesions. In other words, quote, hardening of the arteries, which basically is an inflammatory process. So you can use adrenergic receptor blockers. They tend to have a little more side effects. That was something that we saw. Interesting disorder, Raynaud's. So it's more common than you think. There's two, just to make it clear. There's something called Raynaud's disease, which is what they're describing here, and there's something called Raynaud's syndrome. They are the same thing in appearance. The syndrome typically is associated by some type of uh, inflammatory arthritis or autoimmune disease. Typically, we see it associated with autoimmune diseases. So somebody with systemic lupus erythematosus, and we'll talk about these immune disorders as my portion of the immune system discussion, which is coming up, but not we're a few weeks away from that. But the presentation is the same. It's an exaggerated response of vasoconstriction in the digits, and it's typically symmetrical. Okay. And what happens is the blood vessels are normal colored pink, then they go into spasm and they turn white. And then when the spasm is reduced, there's like a pressure head of blood that comes in, so they become engorged and they don't drain as effectively, so they get bluish in color. And you can use vasodilators, and I think you have to look at what the underlying cause is. Most frequently, some people get it with an unknown cause when they're excited, frequently associated with exposure to shifts in temperature. My first wife had this, so I know about it as much as I do. So she would be sitting outside, and the kids would go swimming, and she'd jump in the pool to swim with them. Then all of a sudden, sometimes every so often, her hands would come out and they start to literally change color. You'd see them turn white and go back to. We used to call it the patriotic disease because the appearance was first red, normal color, let's say, then white when it was in spasm, and then blue when it became engorged. So that's really a very interesting syndrome. You can see it. There's an oddball one that occurs in blood vessels called Berger's disease. Capital Buerger, apostrophe S. The old name was called thromboangiitis obliterans, and people thought it was the same thing. It's not. I've seen it in smokers. It's almost an allergic reaction that causes spasm in fingers and toes from smoking. And I saw at that same vet's hospital, I could see it. Everybody smoked. It was, you could smoke on the hospital floor, or the doctors would smoke in the rooms. I mean, it was just awful. I was no different. And this guy would have a cigarette in his mouth, and his fingers were black, but asymmetrical, where it's just much more bilateral and symmetric. It looks the same on both sides. And the tip of his finger is turning gangrenous. It's the same finger he's all got a cigarette in. You figure. And this, I have not seen this autonomic dysreflexia, autonomic neurons, quadriplegics, and people with spinal cord injuries above T6. I mean, then all the controls you can imagine are not there. And this is what I mean by blah. You same fingers, both sides, generally, more or less. So it looks the same, and obviously simultaneously. I think it's fascinating. You still with me out there in virtual land? Hello? Okay. So we'll start with the endocrine part of the program. I'll give you about 15 minutes of endocrine and send you on your merry way. I heard something. Okay. This is the next chapter. Endocrine. So important. It must be me. Am I making noise? Oh, Greg, your microphone was on. Okay. So on with endocrine. This is the best way to frame it. Your nervous system is for sudden, very, very rapid control. Your endocrine system, long term. Best way to frame it. Somebody's got a mic on, demic it. The idea is that the endocrine system makes adjustments. The nervous system, fractions of a second. The endocrine system, seconds, fractions of a second, seconds, minutes, hours, days. The old story. If it takes longer to occur, it takes longer to go away. That consistently. The endocrine system works in coordination with the nervous system, and indeed, most of the time, just like as you saw in the sympathetic nervous system, it can be triggered by the nervous system. Not unusual whatsoever. We have to have things. It's based in chemicals. That background noise is bothering me. Hey, Greg, your phone's on. Aha! We've muted you. Back we go. So the whole idea of this fascinating system is its remarkable ability to work through chemicals, and the chemicals, by definition, there's subtle changes in hormones, but when we typically, if you're talking about endocrine hormones, the pathway is the bloodstream. It can be a very short journey. It can go through all out your system. Certainly, the hormones travel throughout your system. Sometimes the target is literally the same cell. Most time the target is a distant cell. Sometimes the distance is quite long. Sometimes it's not long at all. The the hormonal aspect of these systems are very specific. Some hormones, growth hormone, insulin, target multiple cells with multiple receptors. Nearly all cells are susceptible to their impact. Sometimes they're very specific. You're going to see ACTH, which stands for adrenocorticotropic hormone, merely only targets the adrenal cortex. Some, we talk about the ones that are involved in the reproductive hormones like follicle stimulating and luteinizing hormone are specific to ovaries and testes. Do they have some impact on other systems? Probably, but mostly that's their major source of impact. That's where the concentration of the receptors are. So, in general, they respond more slowly, but inevitably they last longer, and we study them. And then there's a variety, as there always is, our definition. So, it's a very small system anatomically. There's nothing to it. You've got a handful of glands that are relatively small. It's a massive system physiologically. And you're going to hear it again and again about the importance of it. Okay. So, comparison: rapid versus slow, short versus long, neurotransmitters v hormones, specific locations. They diffuse anywhere the blood reaches, theoretically could be with it. Short distances for neurotransmitters, and obviously long distances for hormones. It's the system that controls reproduction, growth and development, fluid and electrolyte balance, more so than any other, cellular metabolism and energy balance, defensive systems, and on and on and on. It overlaps the signaling compounds that are technically hormones to some extent overlap a bit, and maybe you have touched on them for those in immunology with regard to the category we call eicosanoids or prostaglandins, which act more in tissues and a lot of times are close targets and not necessarily through the bloodstream. But effectively, they're still part of it. And there's a lot of other substances that play a role in mobilizing white blood cells that are there. Glandular definitions. Go back when we talked about skin and we talked about tissues in chapters 4 and 5 in this textbook. The exocrine glands have ducts by definition, classic sweat glands if you look back in the skin. Salivary glands that have little ducts or openings that we're going to see in digestive, like the parotid, sublingual, and submandibular glands. They carry secretions to the surface, whether it's a mucosal membrane like the mouth or it's a dry membrane like the skin. Endocrine glands go directly into the bloodstream or directly into the surrounding tissue. It's almost like they're spit out of the gland or out of the structure, would be a better way to say it, because sometimes cells, in a sense, will produce them. And they're just exocytosed. Typical endocrine glands, there's a nest of blood vessels that surround it. And you might recall when we did the brain, some of you might, if you had one we had the dura mater on, it had that darkened area. That was the capillary bed, the capillary portal plexus that surrounds the pituitary gland that sucked up the pituitary secretions as well, both from the anterior and posterior pituitary. By definition, they don't have ducts. They just secrete the substance into the environment, typically picked up by blood vessels. Laundry list: pituitary, not all, pituitary, thyroid, parathyroid, adrenal, pineal glands. The key link between your nervous system, just like we talked about in previously, when we looked at the sympathetic nervous system and the parasympathetic and autonomics, the neuroendocrine linchpin is that hypothalamus. That's the connection. Blood-brain barrier is weakest, reads the signals, generates the release of hormones that signal either directly into the bloodstream or signal the pituitary gland to release its contents specifically. Okay. And you're going to see, we're going to point out dual glands that have exocrine and endocrine function. Pancreas is classic. Digestive juices are its endocrine or its exocrine function because there's a duct that joins into the digestive system, where its endocrine function, famously, insulin and glucagon. Eggs and sperm from the gonads, estrogen, progesterone, and testosterone, which are endocrine. Eggs and sperms are exocrine. Same deal with the placenta that's there. It releases chemicals that support the growing fetus, yet at the same time, it releases chemicals into the bloodstream to prevent further degree of ovulation. And we're not limited. Fat cells, famously the thymus, when we start talking about T cells, lots of cells in the small intestine, and even in the stomach for that matter, okay, kidneys and heart, etc. Small system anatomically, not much to talk about. Okay. In and around the area, here you can see effectively if you remember your anatomy a little bit, this is the diencephalon, the thalamus, corona radiata. You can see the thalamic lobes, and below it, the hypothalamus. And below that still, in yellow here, is the pituitary gland. And we'll look at both anterior and posterior. Very tiny behind it, you might remember from the dissection, the pineal gland. Looks like a little pine cone, known as the epithalamus. So they're the ones that are there, and very tiny, massively important. Thyroid, and on the posterior aspect, parathyroid. Thymus, not this large in adults, because once we're born, it starts to shrink. Still produces, but it's just less sizable. The adrenal glands, the kidneys themselves, the pancreas, and ovaries and testes. Just again, there's other tissues that secrete that we will look at as well. So in general, hormones. It doesn't always have to be long distance. It's mostly in the blood. Could be in the lymph. Okay. And again, if you're not familiar, most of you should be, or remind you about it, the lymph is a fluid that is generated with products that are too thick and heavy to go directly into the bloodstream at the capillary level. And typically what we see inside of the lymph are larger fatty molecules and microorganisms, particularly, that are sifted through as they work their way back to the bloodstream, but don't enter the bloodstream until it's a large vessel like the superior vena cava. What are you eating, Mr. Puppy? Ah, ah, ah. I see trouble. Oh. Hold on, guys. He got my coin roll. Thank you very much. Hold on. I'm getting there. If you rolled the coins, it would be easier. Not eat the coin rollers. Okay. So, hormones, typically blood and lymph. Autocrines. Interestingly enough, like in the stomach, you'll have a cell that will influence itself. Okay. It'll exert the same effect on the cells that secretes them. When we're looking at enteroendocrine cells, paracrines, locally acting. That's where the prostaglandins, the eicosanoids, come from. So they're really not technically part of the endocrine system because we don't think about them going in fluid or in blood or lymph, but because they work generally in the same area. And then the other business part is categorization. So you have to categorize these. And the way to categorize these is based on what they're made of. And this is the important part, and this will be the last part, I think, for today. Those that are amino acid based, they're either they are derived from amino acids. They are short chain peptides, 8 or 9 typically amino acids, okay? Or they can be proteins and much larger, like insulin. So you'll see these. The most interesting one of these, and I commented on before when we talked a little bit about tyrosine and epinephrine and norepinephrine is the impact of tyrosine. You have two molecules of tyrosine that are placed in sort of an anti-parallel anti-parallel position opposite each other for symmetry, and bond to either three or four iodine molecules to make the active forms of thyroid hormone, which are T3 and T4. Even though they're composed of amino acids which are polar, the symmetry of the molecule makes them nonpolar, and that's a big distinction. All the other hormones that come from cholesterol, by definition, are nonpolar. So, from the gonads and from the adrenal cortex, and that's where it gets its name, from corticosteroids. The eicosanoids, again, it's a fine line. We look at them more so when we talk about function in different systems, particularly immunologically. Those are what they used to call prostaglandins because they originally were isolated from prostate secretions, and they are really long chain fatty acids that have folded in a particular way, and that's what they are derived from, essential fatty acids, particularly things like arachidonic acid. And probably some of you are familiar with that from the biochem part of the program or from previous courses. They only target cells that have receptors. The tissues with receptors have to be, very specific. And in doing so, and again, the ones that are fat soluble, the thyroid hormone and the cholesterol hormones contact internal receptors that directly impact transcription and translation, and all the others that are polar, G protein passageways that are there. And so what do? Plasma membrane permeability, ion channels, directly or indirectly stimulating synthesis of other proteins, activation or deactivation, secretion, growth hormone, insulin, mitosis, etc. And so, again, plasma membrane receptors, G proteins don't enter the cell, all the amino acids with the exception of thyroid, we'll get to it, and the lipid soluble ones, intracellular receptors that can enter the cell. And we won't go through it again. That's the primary messenger. The second messenger systems, typically cyclic AMP, or the PIP2 calcium related things. And we're not going to go through the same diagram that they constantly use and all that stuff, and the cascading and amplification that's there. To me, that's more cell and molecular and biochem related functions, and we don't need to go over that same. I like it. I see the guys running around like racing, etc., and the things that they activate and those chemicals. That's not part of what we're doing here. So you don't have to know about inositol triphosphate or diacylglycerols and then their activations and these other things. I mean, you remember from Smooth Muscle, we talked about it. Calcium acts as a second messenger. Calcium alters enzyme activity in channels or binds to, like it does in Smooth Muscle, calmodulin. And then that activates enzymes. So it's direct versus indirect. And certainly cyclic GMP in certain selected areas. Insulin, the receptor is, so here, the insulin receptor is a tyrosine kinase enzyme. Okay. And it autophosphorylates upon insulin, activating tyrosine kinase for a variety of things. So tyrosine kinase, again, is a big player, and that's probably worth knowing about. And the lipid-soluble steroid and thyroid hormones diffuse complex inside and intracellular receptors, transcription and translation. And then obviously the messenger RNA does whatever it's supposed to do. And they show you the same diagram they usually do with this. Okay. We'll stop there. Early enough since it's not there. And I mean, I really want to do more about it and draw on the board with the negative feedback arc that's so important and consistent with all of these. Look at the ones that are humoral in the bloodstream directly from the nervous system, more or less neurotransmitters, and sort of this intermarriage of different hormones feedbacking on one another. So let's leave it there, and we'll cut it a little short so you guys can get started, hopefully on your weekend a little bit earlier. And thanks very much. And I miss all of you, and I can't wait till Monday. You too. Goodbye.